Hi, my name is Ali Keogh, and I'm an ER physician at St. Vincent Medical Center. And I thought this would be an interesting case to present to review a particular EKG concept. So this was a 66-year-old male, history of diabetes, hypertension. He was actually brought in code 3 for a STEMI alert by EMS. His chest pain started an hour and a half prior to coming in, and the pre-hospital EKG was concerning for ischemia with ST segment depression in V1 through V3. By EMS, he was given a dose of nitro and it reduced his pain minimally. He was noted to be mildly hypoxic and borderline tachycardic, and his blood pressure was stable. So this was the initial EKG obtained when the patient came in the emergency room. So based on this, just think to yourself, what would you do with this EKG? Would you activate the cath lab based on that? And apparently this looked similar to the one obtained prior to patient arrival by EMS. So as you can see, I don't see any ST segment elevation anywhere, but I do see this localized ST segment depression in the anterior precordial leads. So there are several things you should think about when you see ST segment depression in the anterior precordial leads, V1 through V3. The two main things that we worry about are anterior septal ischemia or a posterior STEMI. Hypokalemia and right bundle branch block can cause this as well. But the two main things that I would worry about are anterior ischemia and posterior STEMI. So how do you differentiate these two? Because the pathways for treatment are very different. So posterior STEMIs, they account for about 15 to 20% of all STEMIs. However, they're usually in the context of an inferior and lateral infarction. And in those cases, you typically see ST segment elevation in other parts of the EKG, so it'd be easy to identify a STEMI. However, sometimes it can just be isolated to the posterior part of the heart, and these are less common. It's also the most common missed type of STEMI because you don't typically see ST segment elevation in these types of infarctions. And unfortunately, only 30% are revascularized in 90 minutes. So when you see ST segment depression in V1 through V3, there are several things you should look at in order to identify a posterior STEMI. So typically with a posterior STEMI, it is the reverse of an anterior STEMI. So everything will be a mirror image. So you typically see ST segment depression. You see large R waves instead of Q waves, as you would see in an anterior infarction. And you typically see upright T waves as well. And this would be the reverse of an inversion, T wave inversion that you typically see in an anterior infarction. So it's a posterior infarction is essentially a mirror image of an anterior infarction, if that makes sense. The other thing is that large R waves and upright T waves in a posterior infarction aren't necessary to identify a posterior STEMI, because these are typically late findings in when a patient has a STEMI, an acute infarct. Just as Q waves or inverted T waves aren't necessary to make the diagnosis of a STEMI in an anterior infarction. So if you do see ST segment depression in V1 through V3, and you have a concern for a possible posterior STEMI, but aren't sure yet, what you need to do is get a posterior EKG. And this is where you put 3 leads just on the back, underneath the patient's left scapula, so V7, V8, V9. And this is a way to directly view the posterior part of the heart. And so when you get an EKG, posterior EKG, you're looking for ST segment elevation in these leads. So you actually only need 0.5 millimeters of elevation to make the diagnosis. And I remember learning at one point in medical school that you can flip the EKG, upside down or backwards and, maybe identify a STEMI that way if you're concerned about a posterior infarction. But studies have shown this actually is not an accurate way to evaluate for a posterior STEMI. You actually need to get the posterior EKG. So this is just an example of just that I found on the internet. This isn't our patient. So if you see this EKG, what would be your next steps? So as you can see, there's ST segment depression in the anterior cortial leads. There's a large R wave, upright T wave, that I would be concerned for possible posterior STEMI. You can also see maybe some subtle ST segment elevation in the inferior leads as well. So what would be your next steps? I'd recommend getting a posterior EKG just to better characterize what's going on there. So as you can tell, they kind of cross these off. These are the normal V4, V5, V6 anterior leads. And then here is V7, V8, V9, the posterior leads. As you can tell, there's ST segment depression here, consistent with a posterior STEMI. So back to our case, this is the EKG that they came in with. They actually did not do a posterior EKG. And when the patient presented, they took the patient to the cath lab, but the cardiologist initially thought it was anterior ischemia and did not diagnose it as a STEMI. They said it was an NSTEMI. But they took the patient to the cath lab, and they actually said after doing the cath that it's likely a true posterior STEMI rather than anterior ischemia. As you can see, the LAD is completely clear. There is some circumflex disease and RCA disease. So it was a complicated procedure. They put in several stents, and the post-cath EKG completely normalized. So take-home points, I think EMS did an awesome job in activating the cath lab based on that difficult initial EKG. Always consider posterior STEMI when you see ST segment depression in V1 and V1 through V3. Get a posterior EKG to help differentiate anterior ischemia versus posterior STEMI if you have a question on this when you see an EKG with ST segment depression in V1 through V3. Thank you very much, and I hope you learned something from this case presentation. Thanks.